Just after 12 o'clock here on the Dr. Payne Show, 1-855-55 Dr. Lou, DRLOU, to get a hold of Dr. Lou anytime, info@paincarecanada.com. And, of course, the phone lines here open for the hour for you to call in with any discomfort or questions about your well-being. 416-870-6400, star 640 on cell. How are you, pal?
Good. You didn't go with maladies this week.
I'm not saying that ever again because you hammered me for it. So there.
I love the word. You're the only person that
comorbidities. That's yours.
Yeah,
all right?
Yeah, that's it.
We're even, son. What's going on?
Not too much. You?
Good. I'm good. I'm ready for the clock to turn back tomorrow.
Awesome.
Not really.
Oh, yeah, that's right. I forgot about that.
Spring forward, fall back.
There you go. Yeah, for sure. No, it was a interesting week for sure. A lot of cases came through the door. One that I wanted to start the show with was relatively young guy, came in, long history of just that, I guess, aching chronic back pain type of thing that a lot of people experience. It's been going on, he said, for about 10 years, and hasn't really ever thought much about it, just something he kind of dealt with.
Just live with it.
Yeah, and it was what it was. And I asked him if he had ever had this investigated at all, and he said, nope, never really thought to go get anything done. I've gone to get some therapy here and there, just kind of massage when it's very temperamental or whatever. Nothing major. He's like, but in the last 3 to 4 months, it's significantly worse than it has been in the last 10 years. And so right there, when you start thinking of a long history of spine-related complaints. His complaints were primarily low back and neck area, with the mid-back also affected, but not as much as the low back and the neck. So full spine. And long history, and more recently, a little bit exacerbated in the last 3 or 4 months for no specific reason. It wasn't like he said, I had... I started a new sport, or I've been doing
fell down the stairs or something.
For no reason, just got worse. And so, with that type of history... mechanical things, simple soft tissue injuries, simple sprain, strain, things like that. The research would indicate that on average, and this is on average, with all other things being equal, no other comorbidities, right? Things like that, within 12 weeks to 6 months, your pain should go away. Yeah. Once it starts being a long history of 10 or more years, that's, indicates that this maybe isn't just mechanical. This is where I always talk about maybe we're in that mid part of the spectrum. Maybe we're dealing with something inflammatory in nature, where there's an autoimmune component attacking the joints. But
structural at that point, no longer muscular, soft tissue, it's more bone.
Well, it can affect everything. Definitely with the autoimmune stuff, it will start to affect the joints.
Right.
But once joints become affected, your muscles will respond to that happening. So they'll tighten up, and things will happen in the muscles as well. Just because as the joints, something's going wrong with them, the body naturally will tense the muscles up to try to protect that area, right? That's a protective mechanism. And so... he goes through his history. Then I start asking him some very key questions because I'm tipped off in my head to this sounds maybe like it could be autoimmune. Autoimmune arthritides tend to have some very characteristic types of things that go along with them. And one of them particularly is that they tend to be much worse after periods of rest, especially long rests, like a whole night. So people will wake up in the morning and they'll be stiff as a board. Now, that can happen with mechanical issues as well, where people who just have mechanical injuries tend to be stiff in the morning because of disuse. Your enzymes aren't working as well, and so those muscles are a little tense. However, you tend to get, as you get going within, the first half an hour of your day, you start to loosen up. People who have autoimmune arthritides tend to be very characteristic in that they say it takes a few hours for me to really start moving around and feeling better. So it's a much longer period. Mechanical issues that are just simple soft tissue injuries also tend to be worse with activity later on during the day, that type of stuff, right? Like everything's fatigued and you're just feeling worse. Whereas in the autoimmune, it's actually the opposite, where activity gets you moving, gets you feeling better. And it's really that disuse that really aggravates the issue. And he was characteristic, almost textbook. Like I was checking it off in my head saying, yeah, this very much sounds like something that may potentially be autoimmune. And so I basically told him, hey, listen, at this point, It doesn't sound like it's on that right side of the spectrum where we're dealing with very, very serious, dangerous things, cancer, infection, things like that. I said it also doesn't sound like it's all the way to the left side of the spectrum, which is totally benign, like, you just pulled the muscle and it'll get better in 2 or 3 days. We're probably somewhere in the middle. I said I think a good bet is we take x-rays of the spine, different areas of the spine, because if there is some type of autoimmune attack on those joints, there'll be evidence of it.
And an x-ray, is that right?
Yeah.
Oh,
yeah.
wow. Okay.
Usually not early on, but definitely after a significant amount of time, which he was complaining of a significant amount of time, there would be some evidence. And sure enough, we took the x-rays, and particularly in the SI joints, which is where the sacrum and the ilium meet. Those joints are very predisposed to autoimmune attack. And so what ends up happening is if you look at that joint on x-ray, it should have a nice joint space. It should be normal. As inflammation starts to happen, you'll start to see corroding of that joint. And as that continues, eventually you'll have full fusion of the joint where you just absolutely lose the joint. And then you have an area that's just completely fused. And in this gentleman, because of the long history, sure enough, those SI joints were completely fused, which absolutely explains the issue. And so it was indicative at that point when you see that it's something like ankylosing spondylitis, which is a spine-related degenerative change due to an autoimmune attack often or always that then creates fusion in the spine. And the reason why I thought this case was important was this person waited so long. Yep. A lot of the available tools that we have now, whether it's the different medications that could be used for the autoimmune stuff, the therapies, you can at the very least try to prevent the fusion of the joint. The pain may still be there, but the really important thing with things that are autoimmune arthritides like rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, reactive arthritis, there's a long list of them, is that you really want to prevent fusion of those joints because we've gone through this. Once areas fuse, other areas have to make up for mobility. Yeah. And as those areas have more mobility, they're more predisposed to degeneration and the same process.
Domino effect, right?
Exactly. And that's a very dangerous thing. So, I think it highlights the fact that if things have been going on, I usually tell people that if you have a simple mechanical back pain and it's not better within 6 weeks, even with some conservative therapy, maybe you're getting massage or whatever, and it's not better, then you may want to jump to some more investigation, x-ray, some blood work and things like that to make sure you're not in that middle part of the spectrum.
416-870-6400 star 640 on cell. You have questions, you have physical problems, you have issues, you just want to talk. Give Dr. Lou a call here on the show right till 1 o'clock. 416-870-6400 star 640 on cell. It's the Dr. Payne Show, Talk Radio, AM 640. It is just before 12:15 on your Saturday afternoon here and the first show of November. It's amazing how fast this year has flown. We were talking about it, right?
It is the first Saturday.
Like we've been doing the show a long time, and it's like it's already almost 2018, which is kind of freaky.
That is crazy. Right. That is very crazy.
416-870-6400 star 640 on cell. You have questions, physical, medical, bring them on. Dr. Payne here until 1 o'clock this afternoon. You mentioned about 4 or 5 times in that first segment with your patient, autoimmune. My mom has it. Maybe your mom has it. If you're listening, what exactly is an autoimmune condition?
Okay. Yeah. An autoimmune condition is essentially where there's an abnormal response of your body's immune system to different tissues. Okay. So specifically in that first part, we were talking about ankylosing spondylitis. That's where the immune system is essentially attacking the spine and the joints related to the spine. Now, you can have different autoimmune issues that attack different parts. So, for example, multiple sclerosis is thought to be an autoimmune disease of the nervous system where it starts to affect the myelin sheath of the nerve, which is essentially what carries the electrical signal. And as you start to demyelinate, those signals become hindered, and it can affect that. You can also have things like type 1 diabetes in children. It is an autoimmune response where now the insulin is being attacked and the insulin isn't there. You can have other things where sarcoidosis, which is an autoimmune response, usually in the lungs, where things start to happen in the lungs. So essentially an autoimmune response is where your immune system, for whatever reason, starts attacking its own body tissue. And sometimes some of these things like ankylosing spondylitis that we were talking about in the long term can have an effect on vessels of the heart as well. So it can cross over into other systems. Rheumatoid arthritis, which is something that a lot of people have heard of, is another example of an autoimmune disease, something where something is happening. Now, usually the question becomes, well, why do autoimmune diseases happen?
Right, and the body attacking your own body.
Yeah, and that is much, much more difficult to answer, and it kind of needs to be specific to what the disease is that we're talking about. So if we take the example again of ankylosing spondylitis, when there's a gene marker called HLA-B27 that people that are thought to have ankylosing spondylitis, such as this patient, will have that gene tested. And that's one of the criteria for being diagnosed with ankylosing spondylitis, is for that gene to be present. And so, when you look at things that have a genetic predisposition, the best idea that we have is what's called a two-hit hypothesis. Mm-hmm. So in healthcare and in anything, like in physics, when something is a law, that is what it is. Like gravity is a law. There's no we're not going to debate that. It just is that. But in a lot of science, what we have is theories, and those theories are up for debate, and we can't necessarily prove them as laws. But there's something called the two-hit hypothesis in healthcare, which essentially says that people have a certain genetic predisposition to something, but you also need something in the environment to trigger that gene. Right. So what that essentially means is, in that example of the HLA-B27, probably a lot of people in the population have that genetic marker for ankylosing spondylitis, but not everybody that has that genetic marker necessarily ever gets ankylosing spondylitis. Right. It's the same with some breast cancers like BRCA1 and BRCA2, which are certain genes. And usually what ends up happening is women that are diagnosed with breast cancer, and if they have daughters, they'll be told, go get genetic testing for these genes, because it kind of gives us an indication maybe you're predisposed to this type of stuff. And so that is the potential, that anytime that there's that genetic predisposition, that it also takes something in the environment to trigger that. Mm-hmm. Now, that could be something as simple as just stress, right? Stress is,
no kidding.
Your stress can activate a gene. Maybe it's something worse, like viruses. A lot of, mono is thought to be a predisposition to certain things. Epstein-Barr virus specifically, and so that's thought to maybe trigger a gene for later on in life. So there's a lot of things that can trigger that gene. But essentially, the good thing with the autoimmune stuff is if you can do things to control the immune response, you can limit the effect of that autoimmune disease.
416-870-6400 star 640 on cell. Anna, good afternoon. How are you?
Hi there. How you doing? I'm good, thanks.
Good. What's your concern?
Okay, so I myself have multiple sclerosis. I was diagnosed in 2000, and I had 2 attacks back to back then. I was having symptoms of it at age 23. They kept telling me it was just stress. There was no MRIs back then. So I just lived 19 years of my life not knowing what it was and very symptomatic, right?
Right.
Then in 2000, of course, then we had the MRI. So when I had those 2 attacks back to back, they did the MRI and they said, oh, you have like old brain lesions, many of them in your brain.
Right.
So I've lived for 17 years on no medication. Mm-hmm. And just on very good diets, omegas, exercise. And I'm just being told that I'm coasting by my MS specialist, and, it's just great. And I'm just, keep wondering, I'm so scared. Is this, just going to, evolve, how does it just stop for 17 years? Mm-hmm. I'm very lucky. I'm very fortunate. Mm-hmm. I feel so sorry for everybody else out there, but I'm just wondering,
Yeah, I mean, again, with MS, once there's demyelinating lesions in the brain, that doesn't always necessarily mean that they progress. So a lot, when you actually look at the research, the vast majority of people with MS actually have almost the same lifespan as the general population. So a lot of people with MS can pretty much live a full, healthy life, really? with the exception maybe of some symptoms that they may have. The most common form of MS being relapse remitting, where there's symptoms that then go into remission and maybe never come back. There is a small subgroup of people with MS that have a primary progressive form that can get very bad very quickly and be much more fatal, but it's not the vast majority of people with MS. So a lot of people with MS do have these things. And again, when you look at it, the fact that it's an immune response, an autoimmune response, if you live a healthy life where you have a good diet, you exercise, you minimize stress, all those things that your immune system would otherwise respond to, you can have a case such as yours, Anna, where you can go a very long period of time with not much exacerbation of any of those symptoms. And that's good. And it's basically, I would encourage you to just continue doing those same things that you're doing. And, again, when you look at it, a lot of people with MS have the exact same lifespan as the average population. So there's nothing that says that you have to necessarily get worse as long as you are dealing with it. And so I think that's a good example of an autoimmune condition that you can manage with a lot of lifestyle things.
We'll keep this discussion open. 416-870-6400 star 640 on cell. We continue. Dr. Payne Show, Talk Radio, AM 640. 1224, Dr. Payne Show. We'll continue our discussion. Autoimmune, you have questions, you have comments. 416-870-6400 star 640 on cell. We were talking during the break. Now, maybe it's not the norm. You don't want to, throw stuff out there that's going to, give people false hope or otherwise. But I had a friend who's a young guy. He's a couple of years younger than I am, so he's in his early 40s. And MS, and was wheelchair bound and degenerating quickly, and ended up raising money and went to Russia. To a clinic, some clinic for a couple of weeks, raised about $20,000 or $30,000, and he got something apparently from what his wife told me was actually for cancer treatment. I don't know what the correlation was, but he's back here now. He's still in a wheelchair, but he's got full weight back. He's in the gym. He's looking great. Like, wow! But it's a different thing. Like in Russia, some clinic.
Yeah, there's a lot of interesting things that are done around the world that are very different from the way we do things in North America. One of the biggest things when specifically for me dealing with pain management, and something that more people can associate with, when we look for disc herniations, we often send people for MRIs of their neck or their low back. In Canada and in the U.S., we're doing those MRIs with people laying down. Now, your disc,
we talked about this.
Your disc is a hydrating tissue, which means that if you apply gravity to it, then there's a pressure component. You may cause a bit of a bulge. So theoretically, when they've looked at this in Europe, they've essentially said, hey, you're more likely to see a disc herniation if you have that person in a gravity type of position, because most people are symptomatic when they're standing or sitting when there's gravity applied to it. Versus
so MRI, I'm standing up.
Yeah, so there's different ways to do these things. And so, and then some of the things that we do on this side of the world tend to be a little bit better. The nice thing is, because of how global of a community it is, we have all these things at our disposal. Like you said, though, those things aren't going to necessarily be covered through our private or publicly funded system. Right. So you may have to raise money, or if you have the money, you can go get these types of treatments elsewhere. But I think it is important, for your health. If you're not going to spend your money on your health, what are you going to spend it on? Yeah. And if you can, and not everybody, unfortunately, is in the position, because a lot of these things can be very, very expensive too. But I don't know specifically that clinic in Russia, what they were doing, but I have heard of a lot of different types of clinics around the world for different types of treatments. And it's very, very interesting stuff depending on the issue that's going on. It's
a cautionary tale, though, because you hear of people doing this, especially with cancer, and they say, I'm opting not to do chemotherapy and radiation. I'm going for completely, I guess the word is holistic, organic, whatever approach. Right. Yeah. Really hardcore. And it's like, some of them, you hear good stories. They come back and they're in remission or otherwise. But man, it's like, which way do you go? Do you trust them?
And sometimes you hear horror stories, right? Like, there's been stories of people that are full on, no vaccinations, anti-vaxxers, no medical treatment ever. And, kid gets meningitis or something and they think they can treat that holistically. Kid ends up dying. So there's also the opposite. I think the important thing to remember is that there's a time and place for everything. And we talked about this last week specifically, where, when you look at that spectrum of, let's just kind of divide it with the more traditional Eastern type of approaches, the very holistic approaches to healthcare, and then you have the more Western model of medicine, surgery. I think the beauty of the world that we live in is that all of that is at our disposal. And so I think it's a matter of trying to identify, and I think the harder thing is, when are these things the right thing to be used at the right time? And so I don't think you should ever limit. And something like that, in a case of, you got just the regular everyday cold or whatever, do you necessarily need a cold medicine? Maybe just some, good fluid intake and all that, more of a more Eastern approach might be a little bit better. But, if you've got meningitis, you need to be at a hospital. You need to be getting that treated. That can lead to, full-on brain failure and things like that, and can be very, very dangerous. And so I think it's very, very important to understand that spectrum and know where things should be applied, even on the topic of vaccinations and things. Can I sit here and absolutely say that vaccinations never have an adverse effect? No, nobody could say that. I think a lot of what's happened in the last few years with the anti-vaccination is based on not good research, some research that was actually debunked to suggest that no, it actually is not related to autism and these things. And that's kind of where this whole anti-vax thing happened. But we also have to realize that vaccinations have saved the vast majority of the population from a lot of bad things like measles, mumps, rubella, things that, hundreds of years ago were wiping out a significant, of the vast majority of populations of young kids. And so we have to understand that these things are not bad. There's a time and a place. And, maybe you can make the choice on, now they've got chickenpox vaccinations. I had chickenpox when I was, and so did you. Yeah. So is that maybe as necessary? But I do think that's where your job as a person and a consumer of healthcare, you do your due diligence along with your healthcare providers to have a discussion. And I want to touch on this a little bit more when we come back. Yeah, for sure.
416-870-6400 star 640 on cell. You got an opinion on this? You want to talk about it? Give us a call. You got time. Phone lines are open. Dr. Payne Show. Talk Radio, AM 640. It is 12:32. The Dr. Payne Show. Yeah, 416-870-6400 star 640 on cell. Questions, concerns, comments. We'd love to hear from you. Maria, good afternoon.
Hello.
Hi. How are you?
Hi, I'm good, thanks. How are you?
Excellent. Thanks for calling in. What's your concern?
Okay, I have a senior who's over 80 who has acid reflux. Mm-hmm. Can that be repaired?
Well, what's the acid reflux due to?
We're not sure. It's just that it wakes him up in the morning. Mm-hmm. So once he has breakfast, he's fine.
Right.
But it is bothering him.
Mm-hmm. So this is kind of an example of what I was just talking about in the last segment where, I meet some people who are relatively young and develop acid reflux and they think they need a medication for that. And then when you start looking at their diet, it's like, well, you just kind of eat like a pig and that's why you have acid reflux. And then there's other instances where maybe as you get older, the sphincter that controls the muscle isn't working as well. And that may cause some regurgitation and some acid reflux. Or maybe you have something like H. pylori, which is a bacteria that could be found in the stomach that can lead to acid reflux. So I think the biggest thing is there's no real generic answer for me to say over the phone, here's what this person can do for their acid reflux. I think step one is trying to investigate what is potentially causing that acid reflux. And
right, we've done all of that. Sorry. Probiotics doesn't agree with them. We've eliminated all the food.
Right.
That is causing it.
Yeah.
Once you go through all of that, is there anything else we can do?
Has he had a scope to look at it to see what's going on in the stomach, and everything was fine on that?
It was, yes. Yeah. So he's been taking pills the doctor gave him. Mm-hmm. I took him to a naturopath, and he says that that's not working at all. That's just making other parts of his body painful.
What's that? The naturopathic stuff?
Yes.
Yeah. Yeah. So do the medication that he's on work?
The ones what the doctor gave him worked for a bit, and then he started complaining again. So yes and no.
Yeah. So
it works for a short period of time.
Okay. Well, the important thing with any type of treatment intervention is if there is something that works even temporarily, what that tips us off to is that it does work. Maybe it's a matter of increasing a dosage or changing time. So I would definitely encourage you just follow back up with the doctor who prescribed the medication and just let them know, hey, this was working. It's not really working well anymore. Is there something else? Because there's also combinations of medicines that may be able to get used in that scenario. So this is a good example where depending on what you try, some things will help. And, in another instance, someone may have tried the naturopathic treatment and said, oh, that works really well. And this is where it's individualized. You have to kind of find what works for you. And sometimes these things, again, as you get older, a lot of the muscles, the connective tissue isn't as connective as it used to be. The elasticity is gone. And so that may just be one of the reasons for the acid reflux is that, when you look at it, every organ in our body is still a form of a muscle. And so as you lose that elasticity, things don't necessarily maybe work as well. And it's just trying to find ways to manage it. Sometimes with acid reflux, I've also found it tends to be worse with people when they're laying completely flat. So maybe at nighttime, trying to stay partially elevated helps to avoid those types of things. And so it's a matter of trying different things. But, right. There's not going to be any, I think, clear definitive answer where you could say here you could do A, B, and C and you'll be completely cured. It might just be more of a management issue at this point.
Right. Are there any risks taking the medication the doctor prescribes?
Well, there's always a risk to everything that you do, and that could be there could be a risk to a medication as well as a risk to a manual therapy by a massage therapist. I think the best thing to do is, again, discuss that with the person who's prescribed those medications, because risks. The other thing that when you look at adverse events, there's a long list. Some medications can cause some very scary things, the same as some manual therapies and some holistic therapies can cause some very scary things. It's a matter of trying to couple that with what the person has potentially a predisposition to. And so, like, what's a good example here that I'm thinking of? Someone who is taking, say, something like warfarin, a blood thinner, and there's a chance of, thinning of the blood and bleeding out and things like that. Someone who's otherwise healthy on warfarin may not be as big of a deal. But what if you're dealing with someone who maybe has hemophilia or something like that already affects the blood? Now that is where this person is more at risk. So I think you're the senior that you're caring for. That conversation needs to happen with the doctor, because they'll know the pre-existing conditions, the other comorbidities that are there, his overall health history, and that helps to identify what adverse events are more likely than others.
Okay. Yeah, there's no other health issue, but great. Thank you very much.
No problem.
Thank you, Maria. Appreciate your call. Is it Asaya on the phone?
Asya?
Asya, how are you?
Oh, thanks for taking my call.
Sure, go ahead.
Yeah. Okay. I'm 79 years old, and I have bladder cancer. I had 2 operations, and it's invasive and coming back. Now I'm waiting for third operation, but things getting worse compared with the previous cystoscopy. So I'm thinking, I look in the computer and I saw lots of things about baking soda treatment by Dr. Simoncini. I don't know if you heard about him.
No, I have not. What I can tell you is, again, I think when it comes to any type of cancer treatment, I work with naturopaths who deal with cancer as well. But the important thing is to couple whatever is being done on that more natural side with also what's happening on the more traditional medical side of surgery and chemo and radiation. You never want to do anything that's, just one or the other. And the problem with looking on the computer is there's a lot of things that are not substantiated in good clinical evidence.
Google Med School.
And so you want to make sure. So if you're interested in maybe another alternative or complementary approach to helping deal with your cancer, I would suggest going to see a good naturopath. I could help you find one if you're interested. But I wouldn't necessarily say just start taking recommendations from Google without taking any advice from a healthcare professional. You definitely, and even then, you want to avoid people like on the holistic side that say, no, don't do the
Western medicine.
No, I'm waiting for operations. That's what frustrated me, because I have to wait for a long time. It's a big waiting list. So that's why, just I'm wondering. One more question, that maybe if you know in Canada, there is some other time to do it, to speed up operation, some evening, afternoon, or evening holidays, whatever, with money, or is it impossible? Only one way to wait.
At the mercy of our system, right?
Yeah, and the system is also designed in a way that people who are much urgent, like if you have someone who's very urgent, they don't just say, well, we're going to make you wait 4 months. There are always times reserved for very serious cases. So whoever your doctor is, likely a urologist who's dealing with this, maybe there's not that big sense of urgency, or maybe they realize that doing the operation isn't going to do much more. So I just think if there's a concern on timelines, just go back to see that doctor and see if there's a way to expedite it and have that conversation with that professional that's outlined the plan of management.
Appreciate your call, as you will take more 416-870-6400 star 640 on cell. You got concerns or comments or questions, bring them on. Dr. Payne Show. Talk Radio, AM 640. 1243. Lots of time for you to call in, ask a question, make a comment. Would love to hear from you. Yeah, 416-870-6400 star 640 on your cell. Luann, hello. How are you?
I'm doing great. And just so you know, I'm a great fan of 640 radio.
Oh, look at you.
Thank you.
I love it.
I love it.
What's going on with you today?
Well, I've decided for once and for all, for God's sake, to get healthy. Eating is not my problem because we're vegans. We're vegetarians for 27 years, vegans. I can quit sugar for 2 years, so it's not that particular problem. Mm-hmm. But I would like to ask the doctor his wisdom on. I'm taking Zoloft, and I have for years. Mm-hmm. And I've been told by several people, therapists, et cetera, some doctors say it's really tough to lose weight on Zoloft, and the other people say not to. Eventually, I hope to get off, someday before I pass away. But
right. So can I ask you why, like Zoloft is mainly used for depression and anxiety. Is that the reason that you're on it?
Yes, sir.
Yeah. And so you're trying to lose weight and you're having maybe a little bit of issue losing weight. And how old are you?
60.
60. Yeah, I mean, including an antidepressant type of medication like Zoloft, which is works on serotonin uptake and inhibits that essentially, can it affect your ability to lose weight? It's an antidepressant. So what it actually does is it depresses your nervous system, which in turn will depress your body, which can sometimes lead to just more fatigue, and people that use this just kind of say they're lethargic. And so that may be a reason that, that lack of energy can, potentially create, lead to that. The other reality is that as we get older, it becomes harder and harder to lose weight. So, that I don't think that, using Zoloft will prevent someone from losing weight if they really want to lose weight.
Just might be more work. Right?
Yeah, is what I guess I'm trying to say. Is it maybe, if the option was try to lose weight and not be on Zoloft, maybe there's an advantage to that. I'm not sure. But I think the reality is you have to take into consideration the reality of your situation, which is I'm sure that the fact that you're taking this helps you to function because of the other health issues that you live with. So I think it's important that you continue to use that and maybe have a conversation with whoever your healthcare professional is that's helping you deal with the depression, and see if there's a way to eventually wean off of it or change the type of medication that's being used, or maybe introduce a behavioral type of program like cognitive behavior therapy to also help from that behavioral issue standpoint. But, I don't think it's worth it to go off of it to try to lose weight. You just may have to work a little bit harder at losing the weight is the reality. But I don't think, it's going to be completely prevent you. I don't think you can say Zoloft will prevent you from losing weight. Mm-hmm.
No, I'm not going to say that. And you know what, Doctor, I appreciate you've articulated it much better than I've heard in the past. And I am seeing a cognitive behavioral therapist starting in November.
Oh, they're great. Yeah, fantastic.
I'm glad because I have switched and I've just had so many deaths in the family so quickly.
Mm-hmm. Right.
And it's just been hard, and I'm finishing a PhD, and so my life is a bit stressed at the moment.
For sure.
But I'm going to take that into consideration, especially what you said about the Zoloft can make you feel a bit less energy, a bit lethargic, a bit weepy. I thought, I thought it would help, but who knows?
Well, it's an antidepressant, right? It's designed to do that because the whole idea is the way that you make people feel better that are usually when people are depressed, they're overthinking a lot of things, and that creates like an obsessive compulsive behavior and anxiety component. And so essentially you want to depress the nervous system, and in depressing the nervous system, you just kind of quote unquote chill them out. And that's the whole point of an antidepressant like Zoloft, which is very good for, this is the thing where there might be antidepressants. A lot of people will talk about how they're so dangerous and all it does is numb you out. It's very, very important that someone who's dealing with depression needs that. But I also do believe it needs to be coupled with the behavioral interventions because the one thing it doesn't do is change your way of thinking. And a lot of obsessive compulsive depressive and anxiety disorders are just mainly due to a faulty thought pattern more than anything. And so you need to have both. And this is a good example of that traditional medical surgical approach being coupled with something else that's maybe quote unquote a little more alternative, which is the behavioral side, and coupling those two together will give you the best benefit. And when they look at the research, doing both in conjunction is better than just doing one or the other.
Absolutely, doctor. And I would reiterate for your audience is that I was in therapy for 3.5, almost 4 years before I even decided to start taking. So
right.
I think that's important, like you said, to see where your mind patterns are.
For sure. And using them together. And I think it's good that you're able to do both. And you might be an anomaly to the general population because a lot of people, there's a very big stigma around mental health issues. And a lot of people are afraid to admit that they have some type of anxiety or depressive component.
Sometimes they don't know.
Or sometimes they don't know or they don't realize. And if you tell them, no, I don't want to be on that medication. Medicine isn't our enemy. It's here to help us. And again, used properly, responsibly, and in conjunction with a good healthcare professional who is, making sure that they can wean you on, wean you off, maybe that you need to say at a certain dosage for a long period of time. This is very, very important. People who do these things right have very, very good outcomes, and you need to be open to that, and it sounds like you are, which is good, and you'll have good outcomes because.
Luann, have you ever done any CBT before, the behavioral therapy before this coming in November?
You know what, I have, and I switched to a different type of mental therapy. And now I think I'm ready to go back because I think when you learn more about yourself, I'm more of a pragmatist. I want to get things done and give me a way to get it done. I'm not interested in the whole huge context.
Right.
So I think it's going to help a great deal. We chose someone that's kind of far from where we live, but just seemed like the right fit. So I'm excited about it. The only thing I'm very scared is that maybe I've taken this stuff for way too long. I'm scared about that.
Yeah. And again, go have that conversation. Another good thing, we'll touch on this after, but with medications, have your conversation with your pharmacist too. They know a lot about this stuff and, ways to wean on, wean off it. And they're very, very knowledgeable people to have those conversations with.
Still have some time. 416-870-6400 star 640 on sale. Dr. Payne Show right till 1 o'clock. Talk Radio, AM 640. Getting down to the nitty-gritty here in the last few minutes of the hour, so we'll get to these calls as quickly as possible. Omar, good afternoon. How are you?
Good afternoon. I'm good. How are you?
Thanks, pal. We're excellent. What's your concern?
I just got this big bump kind of thing on my inner side of the thigh. Okay. It's just like I took a shower at night and I just went to bed. The next morning I woke up to take another shower and I felt this a little bit painful bump in there. And I go like, what the hell is this? And I don't know where it came from.
So can you be a little more specific where it is? So it's on the inner part of the thigh. Is it higher up?
It's higher up, close to genital area, but it's not really in genital area, but it's more lower, but it's the inner side.
Yeah. So in that area, and again, I can't be sure because I'm not there to look at you, but in that area it could be something like a lymph node that's inflamed. And so you'd have to get that checked out. Step one is go to a clinic, get an ultrasound ordered, and have a look at what's going on. You'll probably need some blood work too. Do you have any other symptoms going on?
No, I'm perfectly fine. I'm pretty much healthy. I just work like 7 days. Nothing is unusual, but it's just like the size of it just decreased.
Mm-hmm. Oh, did we lose Omar? No, he's still there. Hey, Omar, are you there? Okay, so what do you think if we get him back?
Yeah, if we get him back. Again, in that area, there's the lymph nodes are in that area, so a bump that just swelled.
And we're back. Okay, sorry, Omar, we dropped out there for a minute.
For a while there, Omar.
Continue.
Can you hear me?
Yeah, we can now.
Hear you now.
Yeah. So what it is, like from yesterday till today, the size decreased a little bit and it's less painful.
That's a good sign. So usually lymph nodes, again, if it is a lymph nodes can swell for a lot of different reasons. All the way from, local trauma in the area that just causes inflammation to, different types of infections that can cause things like that. Like, especially in that area, one thing to obviously consider, and I don't know, your sexual history, but STDs, if you've been active sexually with multiple partners lately and unprotected sex.
Nothing like that. The only thing that I do, as I said, I just work 7, and I work like really, basically I lift heavy stuff in it. That's about it, basically.
Mm-hmm. Yeah, so it could also be something like, it may not be a lymph node. It could be something maybe like a hernia. It's not a typical type of place, but, if with your history, again, it's hard for me to be sure because I can't see it. I can't palpate it. But I think for sure if it's happened, go get it checked out. There's, this is something that just going to a walk-in clinic. Sure. A walk-in doctor can check that out, and that's a good start. Yeah, no need to go to an emergency room or anything. A walk-in clinic's good enough.
Appreciate your call, Omar. Fred, good afternoon.
Yeah. Well, hello there. I'm going to try to make this quick, so I know you're crowding time here.
Sure, pal.
7 years ago, left side hip replacement.
Mm-hmm.
Okay, been very, very well after that point in time. Last December, I survived a heart attack, and I've been on blood thinners, and I'm witnessing quite a bit of energy depletion, kind of struggling. But in the middle of all this, I have a very weak back. I mean, and I guess the formula was the right side may have to be done. I had checked that out. That isn't the case. I did, in my use, I tore the sacroiliac, if I could use that term. But that muscle now is really permeating and hurting me on the right side. I'm equating this as because I might be on. I don't have the strength because of the blood thinners I'm on right now. Don't know what to do about this. I can hardly stand up in the morning sometime. It takes me a while, and I'm crawling up the stairs at night.
Mm-hmm.
Right.
Let's leave it at that. What do you got to say? Anything that can come immediately to mind based on what I said relative to the heart condition?
Well, I think a couple things here. The fact that you had a hip replacement on one side and then you're suggesting that you likely would need it on the other side. Hip issues can definitely create pain in that area that you're describing. Could it be compounded by the fact that, you had a heart attack and now you're on different medications? You maybe were also immobile for a period of time and things like that. That could just be compounding the issue and maybe further exacerbating it. But, based on your history, to me, it sounds like it's probably primarily related to degenerative changes in that right hip. Now, you'd have to have an X-ray to make sure.
I did. I had X-ray in the right hip, and total observation ultrasound, and there's no reason to go on with a hip replacement on that side yet.
Oh, okay. Well, that's yet. Now, what does that mean? That means there's degeneration, but just still not to the point that the left side was on?
I don't know whether that's an insinuation that it could be necessary or not.
Right.
The fact is I'm not a candidate right now.
Okay, so that doesn't necessarily mean that you don't have any degeneration in the hip. And the thing about hip issues is they tend to use a hip replacement is very good for people who have that very sharp internal groin pain. Yeah, another sequelae of...
you hit the nail on here. Hang on, if I could may interrupt. I do at times when I'm getting up, maybe come out of bed at night to go to the washroom, I have a streak of pain that I've never witnessed this until about the last few months, down on either side of the balls. Down into that area, it'll strip. It sort of holds me back. Your comments on that, if you will, please.
Yeah. So again, there's a lot of the nerves that go into the legs also go into the pelvic area and into the genitals. So if there's anything going on with the nerves in that issue, it may be catching the nerve and creating pain in other areas, not just the leg, but also into the genitals. And so that may be an issue. But I think again, your overall history is more complex than doing it justice just on the radio. Come see me for an assessment. We can look at everything and try to determine what the cause of that pain is.
1-855-55 Dr. Lou, DRLOU. That is the number now. The show is done for another week. 1-855-55 Dr. Lou or info at paincarecanada.com. Till next time, the Dr. Payne Show, Talk Radio, AM 640.